Hi everyone, welcome to the slide set for week 4. As you can tell by this first slide, this is looking at something that's also part of the Professionalism 2 class that I did in semester 2, and that was around reflective practice. And some things we're going to think about again is recovering again, what is reflection? What are the challenges? How does that drive clinical decision making? What is this STRIVE thing that some of you have looked at with the CMTO? The commitments to change, and something called imposter syndrome. So some of this I'll be heading, looking back a little bit to what we took in semester 2 as it relates to some of these things. So ask yourself the following question, and I will be asking this at class this week. What is reflective practice? What is it and what it is not? So, when we think about the fact that by this point now you have been doing a number of reflections in the clinical setting, you've been doing some research on research and textbooks and so forth to help you along with that. But ultimately, what is it and what does it mean to you as a practitioner in terms of utilizing reflective practice in your day-to-day business stuff? So what is it? It is a conscious and systematic approach to thinking about experiences with the aim of learning and changing behavior. If you at all remember in semester 2, there was something called the Kolb cycle that you went around in terms of approaching and reflecting on what was happening to you or what you were experiences in clinic. And it was a systematic way of looking at it with the aim of maybe making change, whether that's change in behavior or whether that was change in practice or whatever it might have been. So ultimately, it's becoming conscious about what it is that happened within that experience, learning about that experience, and then out of that learning of the experience, is there anything you can change? And then you remeasure the change to see whether or not it was a good outcome or not. So we have to think about that again, that Kolb cycle that we talked about in semester 2. So reflection basically can be the experience itself. It can be the actions within the experience. It can be the emotions that you're feeling in the experience, feelings and responses to certain things that are going on. So ultimately then is you combine what you already know and what you may be doing within the context of your practice or your experience, and then putting new information into that experience to see what happens. So the goal is to combine what is already known with new information that results in drawing out knowledge, new meaning, and a higher level of understanding. So ultimately, you have certain knowledge that you do, and you apply this, thing that you might be doing. Let's use, a technique, for example, that you were told would work in such and such a condition. And then maybe things didn't work out the way it did, so you want to delve into finding more information or new information in regards to this technique to discover maybe how it could be done better or differently, to gain a new or higher understanding of the approach you may want to take or how you may change the technique in terms of the utilization in regards to a pathology or a condition that your patient has. So when we think about integrating this reflective practice or integrating reflection into your day-to-day practice experiences, whether that's still here at school or whether that's what you're out of here and you're practicing on your own, think of some things in terms of why it's important. First of all, enhancing patient care. This goes all the way back to what we talked about in the first part of this semester was, by doing research and keeping yourself current and expanding your knowledge, that enhances your ability to make your patients have better outcomes within your treatment plans. It also helps bridge the gap between theory and practice. So, you have things that you've been searching in terms of research that suggests different theories and approaches. You have the opportunity through reflection to practice those new approaches and maybe see that, yes, what they're talking about does make for better outcomes for my patients and so forth. Reflection can also help resolve practice-related problems. Remember the 2-chair, 3-position thing that I did in class where you were to reflect on thinking about your feelings about the experience, both the feelings and the other individual or the other person's feelings, to try to open up and reflect, to look at all sides of something. So maybe if you're looking at problems within the context of interprofessional communications, those sorts of things, it could help resolve some of those problems that you seem to find yourself into. Also stimulates critical thinking for practice changes. So when we do the reflection and we come around in that Kolb's experience cycle, it may end up changing your practice. So no longer am I going to perform technique A because of a number of reasons, and I've found that B works better, and you move on to that, thus changing your practice. So, a reliance on protocol and habitual responses works well as long as the world does not trip you up by refusing to conform to the shape you anticipate. So this is the problem, is that all of you have learned how to come up with protocols and create habitual responses to the things you see in clinic. You start to build these up. But the problem is the world is ever dynamic. Patients are ever dynamic. Things are changing all the time. Patients' reactions to pathologies are different all the time. So the reason we need to reflect is because our experiences within the context of this dynamic life just will never be the same. So this is what you need to think about. I'll repeat it. A reliance on protocol and habitual responses works well as long as the world does not trip you up by refusing to conform to the shape you anticipate. So you have an idea of what it's going to be. The patient walks in. You know they have a particular condition, and yet it doesn't walk like a duck, it doesn't quack like a duck, and it doesn't move like a duck, and yet you know they are a duck. How are you going to reflect on that and make the changes that you need to make in order to recognize that the world has not, or the patient has not conformed to the shape that you're anticipating? So I remember, doing all this work in semester 2 where I have all of you start to delve into yourself to think about what your biases are and what your philosophies are and where those sort of things come from. How do they build in you? Because you start to take shape within them and you start to integrate them into you, which you start to think that they're your ideas, your biases, when in fact a lot of times they're not, and that's why I do it. So we are our assumptions. Assumptions are the taken for granted beliefs about the world and our place within it that seem so obvious to us that they do not need to be stated explicitly. What does that mean? Assumptions are the taken for granted beliefs about the world and our place within it that seem so obvious to us that they do not need to be stated explicitly. And when we think about assumptions, because everybody knows the term, and it makes an ass out of you and me, right? To assume that we think when we look at something that everybody else looks at it the same way we do. So therefore, we don't think we have to state it, because if I'm looking at something and you're looking at something, we both may take the position that we're both seeing the same thing, and we may not, because of our experiences, as we talked about, in that second semester, our experiences, our upbringings, our philosophies, and so forth. Assumptions do give meaning and purpose to who we are and what we do. In other words, they're a frame of reference when we. So we have to remember, and that's why I had you do a lot of the things that you did in semester 2. Once we start to open up and look at what those assumptions are and where they come from, it gives us pause to reflect upon why, and do we really believe those things we always thought that we did? Do we look at the world differently? Do we begin to recognize then that what we're looking at in the world is not necessarily the same as what everybody else is looking at the same time? So when we look at reflection, what does it need to do? It needs to challenge you in terms of looking and understanding yourselves better. And within that context, then, what are your attitudes and what are your behaviors? And as we know, I'll say it again, we did a lot of this work in semester 2. I don't know how much you integrated that or utilized that in your practice setting, but I'm hoping that some of the things we talked about and did in that semester 2 session in terms of discovering who and what you are, hopefully some of that bubbled up when you were in the clinical settings over the last couple of semesters. I will be talking about this in class on Friday, and I am hoping that some of you can come forward and discuss where having a better understanding of who you were in the context of what was happening in the clinic made for a much better experience. So, as we know, that when you reflect and challenge yourself, you start to identify your biases. And I will ask you, do you remember what a bias is? And if you could bring that to the table on Friday, that would be great. So, evidence-based practice and reflection. Where do they all fit in together? The role of reflection in evidence-based practice is to help the practitioner integrate the research findings into practice, or gain a wider knowledge base and experience adapted to suit individual circumstances. So, the reason we've brought reflection back into the role here is because through reflection, you may be able to better integrate these research findings. I found it quite fascinating last week when a number of you stated that you weren't happy with the research that you were reading last week in terms of the pre-reads. And remember that in the first week, when some of the stuff I brought forward in the research there, they were saying that, practitioners generally tend to accept the research that solidifies or is positive in their own experience, and they don't like it if something is suggestive or goes against the practitioner's biases when looking at it. Reflection helps you identify or ask yourself, why did I feel uncomfortable with the research that I was reading last week? What was it about that research that made me feel uncomfortable, and why did I feel that way? What are my biases, and how did that reflect on my ability to objectively look at that piece of research and see if there's anything at all I can take out of it that would help my practice, even though maybe I wasn't happy about what it stated or what it was suggesting. So when we talked about, and again, the second semester, we talked about practice or reflection in practice and on practice. So remembering that reflection in practice is the real time, maybe while the hands are on or while you're doing an assessment. You're reflecting within the context of the real time what's happening. Why did the patient just move that way? Why did I feel that it wasn't done properly? What was a technique, and why did I not get the outcome I wanted, and so forth? And remember that reflection on practice is after the fact, right? Looking at the experience after the fact and having a sense of what's going on there and reflecting on it. So when we say then here that reflective practice typically occurs in a potential situation or problem and a negative event or problem. So this is when we start to go, I wonder what happened here. Why is this going on? That is reflection. And it's not always negative. It can be a positive. So the suggestion is that in most cases, we tend to reflect more readily when we come out of a more negative experience. Why did that happen? How could I make it better for next time? Please remember, though, you also need to reflect on how did that work? Why did that work out as well as it did? What things occurred in that experience that resulted in such a positive outcome? Because I need to reflect and remember that as well. It's vitally important. So this is a bit of a different reflective model. This is Gibbs' model. We looked at Kolb's last time. So when we look at this model, there's a lot of similarities to it. It just adds a couple of things, but ultimately it's the same. So we have the description of the problem, reflecting on, what happened. How did you feel about it? So exploring, why you were happy, sad, mad, whatever it might have been. Evaluation, which is, the positives out of it, the challenges. Analyzing, so making sense of it, coming to a conclusion, and creating an action plan. So again, very similar to Kolb, where you are going through these steps, with sort of number 3 being, to me, one of the more important parts of it, because that's that dig down deep. Evaluation really does describe a lot of the reflection. So there are many occasions where current evidence does not advocate a particular practice, and it is in these situations of clinical uncertainties that reflection has great importance. By enabling your personal experience and knowledge gained from it. So, although, sometimes we get frustrated and we come up with something and we try to find a bit of research on it and we really can't find a whole lot. That doesn't mean that it's not important, and that doesn't mean that you can't gain knowledge from an experience, even if it can't be supported by evidence or research. So when we use reflection, it does help us gain some knowledge from the experience, even in the presence of not having enough information to help you. So in other words, we're informing the decision-making processes with the absence, shall we say, of evidence. So remember that reflection does help us in the environment where we don't have the evidence that we were hoping to find. Clinical reasoning is a multi-layered and multi-component capability that allows practitioners to make difficult decisions in the conditions of complexity and uncertainty that often occur in healthcare. So let's break that down a bit. What is clinical reasoning? We tend to use the term clinical reasoning instead of diagnosis because we're reasoning to ourselves that whatever we're seeing, whether that's a lack of movement in a joint or a particular type of pain that the patient is expressing, we start to reason that means something. So it is multi-layered, meaning that when we try to reason something, we're bringing a whole lot of knowledge and experience into that reasoning. Right? So we've learned, the signs and symptoms of a disease. We've learned the patient may express the pain in a particular way, sharp, dull, achy, so forth. All those things start to layer into our reasoning, as well as components. So we provide tests, we have questionnaires, we use outcome measurement tools. So all of these things help with our clinical reasoning. So then we say, it is to make a difficult decision in the conditions of complexity and uncertainty. So you are making a difficult decision because what the patient is showing you could be of a very complex nature. Their inability to perform tasks, their expression of pain, their diagnosis from imaging, and so forth. So conditions of complexity and uncertainty that often occur in healthcare. So again, reflection helps us in this, because you may not recognize that even when you're doing an assessment on a patient and you're taking those very brief moments of, why is that happening and what's going on here, and I think it's this or I think it's that, that in essence is reflection as well. So such decisions require a high level of tolerance of ambiguity, reflexive understanding, practice, artistry, and collaboration. So let's think about this. High level of tolerance of ambiguity. What does that mean? What does, if something is ambiguous, what do we say that is? Does that mean it's very informative? Or does it mean it's wide open and open to conjecture and interpretation? Reflexive understanding. And again, if you remember in semester 2, I talked about how the more experiences you have, the more you will reflexively move to doing a next step or reflectively understanding what's happening. Yes, that makes sense because this is what I'm thinking. Practice artistry. I love that term because it really does express massage therapy in so many levels. We do a lot of science work, which is very important, but ultimately what we're doing when we're touching our patient is a form of art. Although we have to remember that our ability to have a practice artistry comes from a deep, large reservoir of knowledge and experience that we get when we're working. And of course, collaboration is always keeping in mind the patient or maybe other peers in a multidisciplinary setting and so forth. So when we look at practice, reflection in ourselves, I don't know if you guys have heard these terms before, epistemological and ontological. I mean, these are basically, when we look at them, it's about reflecting on our practice. So, what am I doing? What are my hands doing? Why did my hands do what they did? Why did I, ask to do a particular movement in an assessment, and so on and so forth. And of course, the second part is about who am I? What are my biases? What are my beliefs? Where did they come from? And if you think about this, in professionalism too, we did spend a fair amount of time in number two, in ontological thoughts and knowledge. I deliberately tried to get you to start to look at who you were, what you bring to the table within the clinical setting, and how knowing that, as I said in semester two, will help you without to prevent inappropriate reactions or outcomes, because you won't be caught off guard with something that you didn't know would affect you. Doesn't mean it's not going to happen. It still does, even though we work very hard at getting to know who we are. But it certainly does help if we've taken the time to learn as much as we can about ourselves. So when we look at sort of clinical decision making, what kind of knowledge do we need? We need propositional knowledge, we need professional craft knowledge, and we need personal knowledge. And again, we sort of went through this in semester two, but ultimately, we just want to quickly go over them. So propositional knowledge is usually the novice practitioner, usually comes from books, courses, but doesn't have the experience. And again, we did talk about this in two. So we have to understand that even now you're still somewhat, you're probably a little bit beyond a novice now after being in semester five, but you still have a long ways to go. You do rely, within the context of this propositional knowledge, you rely on theoretical knowledge. So what do journals say? What do research methods, pieces of research articles that are random control trials or otherwise, what do they say? And we rely on the outcomes of those particular forms of knowledge to inform us to move forward to do things. We generally tend to have a very inflexible form of practice because we haven't yet had enough experiences to start to delve out into creating our own things or reacting in a different manner that's more true to who we are ourselves. So these are students and new graduates, and that this is where you guys kind of are. The professional craft, of course, is having lots of experiential practice occur. You've seen lots of patients. You've seen consistently lots of patients with particular pathologies and how they present and so forth. And this relies on tacit knowledge and practical skills. So, for example, joint mobilizations or releasing soft tissue, hypertonicity. The process of these things becomes more fluid. It becomes more effortless. You're just sort of moving through it, and you're allowing your intuition to drive you and move you forward into the experience. And of course, the last one speaks to itself. What's your personal knowledge? What's the unique frame of reference you have within you? What do you know? And this is why we go out and we take extra courses after we graduate, because this starts to increase your personal knowledge and knowledge of yourself. It could be directly craft related in terms of, learning new techniques or approaches to things, but it also could be getting a better knowledge of yourself, helping yourself to understand. This might involve seeking a counselor to have conversations about why you act the way you do, or how to help you through challenging times. But basically, personal knowledge comes from your ability to reflect on your own experiences, taking the time to look in at yourself as to why you did what you did, what caused you to do what you did, what are your biases, what are your philosophies. And again, we did a lot of this work in semester two. So when we look at expert, then they use analytical skills and intuition together, where the novice uses just the rules and guidelines. With an expert decision, it's often difficult to explain and have no rational process. So you just know it took you in that direction, and you moved that way. And it wasn't that you could really put your finger on what it was that caused you to move that way, other than this intuition. And intuition is nothing more than self-reflection on experiences, self-reflection on yourself and your knowledge, your biases and so forth. This is where this intuition come from? So an expert then has the ability to pattern match or pattern recognize. So in other words, to combine current experiences and past clinical experiences that help you come up with a clinical decision. You've got something to look back on within your previous experiences to inform you that much better to move forward. In other words, you develop an intuitive grasp of the situation that's there in front of you. And all of this comes from your ability to take the time to reflect as you move through on all these different experiences, and then to take the outcomes of those reflections and sort of create a mental sort of database where you can come back to it time and time again. And this helps develop more and more this deeper intuitive grasp. Evidence-based practice approach, expert clinicians are expected to justify their decisions and, where appropriate, use research to support their actions. Evidence-based practice approach expert clinicians are expected to justify their decisions and, where appropriate, use research to support their actions. This is why we are starting you on this path of digging into some of these pieces of research. And my hope is that you will, through the conversations we're having and these articles that you're reading, your practice will start to change. So, question for all of you, we'll ask it on Friday. Maybe write this down, your answer to this. How do practitioners articulate their knowledge and then pass it along to other practitioners? What sorts of things do they do? What can they do? What would your expectation be from someone who is an expert practitioner? How would you want to, have them articulate their knowledge so that you could learn from it and gain from it, and then affect your own practice? We will talk about on this on Friday. So here we go. Remember what I said. Reflection on action is usually the novice practitioner. It occurs after the event has happened. So this is maybe when you're sitting down doing your note-taking, the patient has left, and it's about thinking about what happened, what was done, and was there anything that would change next time that would have changed the outcome? Experience to knowledge. And as I said in semester 2, and sort of alluded to here a couple times, what drives this is your beliefs, your expectations, and your biases. And all you're doing is you're acknowledging them when you reflect on what happened in that experience, looking back. Inaction, of course, is on-the-spot thinking on your feet. You gain understanding in real time while you're working. So to have reflection in action, and this is a conscious attention to the task at hand. And this is where you've heard me say before, how I get somewhat frustrated when I see patients who tell me that all their practitioner does is chatter about themselves while they're working in the context of the treatment. My question would be, if this is what's happening, then how are you possibly reflecting on what it is you're doing in real time while you're treating your patient? And then within that context, you will get to a point where you're reflecting on what you're doing on the spot, and then you are starting to reflect and, let's say, scroll through your mental database. That's what this meta-reflection is. You're reflecting on this mental database that you have of all your experiences, and you start to have the ability to pick out what's going to relate to what you're doing in real time, and then maybe make minor adjustments. And maybe some of you already started this. You've approached a tissue, and maybe it was an elbow or a fist or something you were using, and upon reflection, you think, yeah, I know what, this isn't working well. I know last time I worked on a different patient, I used my thumb. And it's just as simple as that. Don't make it too complicated. Just understand that you are in real time making alterations to what you're doing based on the knowledge that you have by reflecting and looking both in your past and what you are right now. So when we think about reflection and clinical reasoning, thinking and decision making equals best judge action. So again, when we think about our patients' reliance on us to perform to the best of our abilities and to get the best outcomes we can for our patient, this is where reflection and clinical reasoning go hand in hand in a relationship. because it helps you come up with a good, best judged action to use in the context, let's say, of the treatment. So you through previous research that you've read, previous experiences with your patients and so forth, you start to come up and say to yourself, okay, this technique, whether it's a stretch, a strengthen, a hand technique on applying massage and so forth, it becomes best judged because now you've started to think about what you reflected on to work with it. This only gets better over time. So the more experiences you have, the larger your database becomes, and the more you can pick and choose and reflect on to create better actions. This also does include critical self-appraisal. So, did I do the best job I could? Why didn't it work out? Was there something I could have done better? And this is done through it. And of course, and then awareness of one's own thought processes. So metacognition. So why did I think the way that I did? Is there a better way for me to think differently? Again, to achieve better outcomes. So when we think of clinical expertise, then we can say here then that this is the ability to clinically reason, reflect on practice, and embrace lifelong learning in relation to propositional and non-propositional knowledge. So, in other words, if we look at the slide, we have our clinical expertise, all the things even that you've done so far. You're in semester 5, you've had a fair number of clinical expertise based upon those experiences. So within your expertise, you start to look at what is the best available evidence to help me perform better. And also at the same time, because remember, this is evidence-informed practice, what are the client's preferences and values within the context of what I'm doing here? So this is the ability to clinically reason, reflect on practice, and embrace lifelong learning in relation to propositional, remembering the textbooks and so forth, and non-propositional, we'll call that intuitive knowledge. So this is what clinical expertise actually is. So when we look at this diagram here, we've got everything sort of stuck in together. So this is sort of our professional practice. It's complex, as you can see here, extremely complex. It's unpredictable because we never know what's going to walk in the door. We never know how our patient's going to react personally, or we never know how what we're going to do is going to affect our patients in their values and needs within the context of treatment. So we need to recognize this is complex and very unpredictable. And because it is, we need multiple decision spaces. And if you can imagine when you're starting out and recognizing that all these things come into play within the context of treatment, the novice is going to look at this and go, oh man, how am I ever going to integrate all these things into my decision making and reflect upon them and become that great therapist I want to be. But recognize is that even as a novice and how complicated this seems, the experienced practitioner, because of the complexity of all of this, also finds this challenging of all the things they need to think about. So if we look on this side of things here, we have the meta skills of critical conversations, knowledge generation, practice model authenticity, and reflexivity. So basically, how do we have great critical conversations? How do we generate our knowledge, make it better? How are we true to what we are in our practice in terms of our hands-on work in our case, or interview skills or so forth? And how well do we reflect on all of this, how do we reflect on all of this in terms of making ourselves better? So on this side, we have practice, knowledge, reasoning, and metacognition. So we've got, costs and resources within that context. What are our ethical considerations? What is our professional bodies and so forth? What do they say? How do we make ourselves as professional as possible? We also have the client's needs and perspectives, so we have to recognize that they're part and parcel. And if we're working in a clinic, we also have to have the workplace rules and norms that are asked of us here. So how do we work within those norms, as well as our ethics, legalities, and professionalism as well. Down here we have the players are the clients themselves, the carers, which is could be anybody within the caring part, the practitioner, which could be us, or the carer, our colleagues if we work in a large area where we are working alongside people, and the agencies themselves. So maybe we're going into a long-term care agency, and we have to think about their needs as well in terms of the full agency. So within this also we have your perspectives. How complex is this task that you're being asked to do? And then so we have macro decisions such as diagnosis, meta decisions, which is critiquing what you're doing, and micro decisions. For example, what's the next test I need to do on my patient based upon the outcomes of what I just did? Where do I go next? Ultimately, this entire model that's here represents what anyone does in the context of clinical care. So this could be a doctor, a dentist, a massage therapist, a physiotherapist, a chiro, it doesn't matter. We all have this type of complexity in our professional practice. I'm not sure why this is here. I didn't put it there, but I'm assuming it sort of represents, we think of money, we think of freedom. We are somewhat chained down by our patients and our rules and regulations. So I guess you could say this kind of represents the full challenge of all the things we want to be, all the things we need to be, not just for ourselves, but for our patients and the people we work with. And at the same time, we want to be free to make the choices and decisions that we can best make and maintain our authenticity to ourselves. So when we think again of clinical reasoning, then it can be a social process. So what helps us is bring our peers in on this. So this is why I don't think I've had you guys for long-term care outreaches, but I like to have pre and post meetings. I like students to present the patient of the day and talk about how they came to the conclusion they did, what their treatment plan was, and why they chose that treatment plan, and then have their peers kind of ask questions and maybe give forth more information. This is when we're working at our best in any healthcare setting, is when we're being open to our peers about what we're doing, asking for input to see if there's anything better we could be doing. This only helps us with our clinical reasoning. If we don't, it's very difficult to get out of your own perspective. I mean, it's really hard for us to get out of our own perspectives anyways. It's just it's what we are as human beings. We come up with something and we don't really like the change. But when we have clinical reasoning and we involve people with it, it helps us to get out of our assumptions and biases and look at things differently. Again, the 2-chair, 3-position thing. Some of the other work that we did in semester 2, I'm pretty sure, I did have you guys in semester 2. I got first thinking for a second that maybe you had Anita. But you can see how important this is for us to, shall we say, get out of our head and start to think outside ourselves in terms of the care for our patients. So whose perspective? Practitioner, patient, and peers. So when we think about those things with the critical reasoning, we have the practitioner within that perspective, we have the patient, and we have the peers. So when we add those in, we have 3 types of clinical reasoning. We have hypothetical deductive, which is meaning, you come up with an unproven reason or hypothesis. So you have hypothetical reasoning. You have pattern recognition. So again, this is reasoning where, when you do a bit of research and you start to look at a disease and you start to see patterns of signs and symptoms, so that you start seeing patterns. So if you've been told that, a particular condition has a particular rash, say lupus with the wolf mask on the face, that's a pattern recognition you start to build when you see your patient with it. And then, of course, there's narrative reasoning, which is exactly that. It's about having a narrative to reason to it. So listening to a story or listening to someone else's experience and narrating it through as far as coming up with reasoning. The last part here is the imposter syndrome. So we believe that if we do not look as though we know what we're doing, then our patients, colleagues, and superiors will eat us alive. And that is a really bad habit to get into, although it's rampant in healthcare. No one ever wants to seem that they don't know everything in regards to expressing help that they may need through a patient experience or something that's going on. And we need to get out of that. We need to recognize that it's perfectly fine to have something show up in your office that you don't know and to go and ask someone about it. I when I worked in the hospital, long before all this privacy stuff was occurring, I would see physicians in the hallway having a conversation. Hey, John, I got this patient and here's how they're presenting. I've never seen this before. Have you seen this before? Like, what do you think it is? What might it be? Rather than trying to be the imposter. So we wear an external mask of control, but beneath it, we know that really we are frail figures struggling to make it through the end of each day. And this is something you have to recognize, because if we don't reflect, this is where we end up. We end up trying to project that we know everything, trying to project that, that we're A-okay, that if anybody knows that we're not, then this is going to not bode well for us. So I'm going to start to be the imposter to make everybody know that I absolutely know everything, even though we may be struggling. So for people who are desperately trying to avoid being found out, the last thing they want to endure is a systematic scrutiny of their practice by colleagues. As well. I do apologize about the little break in the middle there. I kind of got fixed up there, so it probably jumps around a little bit there, but ultimately you get the idea of the whole thing. So in regards to what we've been talking about here about reflection, imposter syndrome, and the message he gave us there was, don't be afraid to go and ask for help. You can't know everything about everything, and it's not a bad thing if you you let people know that you need help with something. So within that context then of reflection, we know that the CMTO wants reflective practice. That's something they're very keen on us doing. And there were a couple of systems that they did use in the past in terms of what they called quality control. So we used to have to do two things. We had to sort of fill out a form that talked about us, looking in on ourselves and seeing, taking the time to see where we were at personally, identifying areas of concern that needed to be improved, and sort of writing up, some things we might want to do and in terms of getting better or recognizing those shortcomings and trying to work through them. And then on top of that, we used to have an audit where a peer would come in and go through all your office and your treatment space and look at some charts that you did and sort of measure you against all the standards in terms of what was required. They have since moved into, as of this year, something called Strive. Strive recognizes that an RMT's abilities evolve over time with focused engagement in continuing professional development that supports lifelong learning and performance improvement. So the idea being that, you are consistently taking things that educate you, whether that be from reading research or journals, whether that be taking courses that are offered for showing you a different way of looking at things, or review of something such as assessments that you haven't done in a while, whatever it might be. This is what they hope, that that your abilities, you do want them to evolve. That's the important thing. And evolution can be done by increasing knowledge base, and knowledge base can be increased by journals, research, courses, and so forth. So, driven by growing experience, learning from peers and colleagues, and engaging in further education and training opportunities, the career path of each RMT may differ significantly, with the knowledge, skill, and judgment-making abilities evolved throughout their professional career, because each of us will have different experiences. Each of us will have interest and expertise in particular areas where we want to further improve ourselves. And the CMTO recognized that they had to come up with a tool to some degree that recognized the diversity of experiences and the diversity of the types of practice that can occur in the massage therapy membership. And they've kind of come up with this strive. So as a result, RMTs that possess diverse and sometimes focused abilities are very much in the interest of clients who may require advanced client care. So this is something I want all of you to think about. Many students come out of school thinking that they've got everything that they need for the rest of their career to be a successful massage therapist. I'm going to tell you that you do not. The mandate at Georgian College is to create an entrance level therapist, which means that you know a whole lot about nothing. If you want to use the cliche term that our grandparents and others have said, you know a whole lot about everything, but there's still so much more to learn. And what we're saying here is that the more you reflect, the more you increase your knowledge base, the more you will start to achieve better results because your abilities become more diverse. Your experience, this mental database becomes larger, and you have something to pick out of to come to better care of your clients. In the early days, you will look after a client and you will seek out a peer of experience and say, okay, I got all this stuff. I just don't know what's going on here. I'm just not getting this. And they may take one look at it and within 5 minutes tell you what's likely wrong. You too will get there, but it does take time and it does take experience. And when I have students in later semesters, and unfortunately I didn't see you guys, going through, if you took the time to just reflect on where you are now compared to where you were 5 semesters ago, your knowledge base is extraordinarily large. And you have so much to choose from to help care for your patients. But please remember, there is yet so much more to learn. And that entire career, you are always learning. You are always recognizing that new research at any time could change everything, and that your responsibility as a caregiver is to stay on top of that and make those changes as knowledge becomes larger. So when we look at this Strive then, and keeping that in mind, Strive understands that the RMT's career path is unique to that RMT, and it can be as diverse as the number of massage therapists there are in Ontario. Strive's personalized approach is built on 15 career span competencies, and these provide a framework for you to manage your practice throughout your entire career span. So the idea is that you're not just doing this once, you're doing this Strive document for the CMTO as you continue on your massage profession throughout your career. The fact that there is so much diversity in what massage therapists do, this Strive process needed to be very broad in nature, and so therefore these career span competencies needed to be relatively broad in nature as well, to allow the variation of all the different things massage therapists are doing to come through, allowing it to be documented and to help. So this is also set up so that each individual therapist can individually help themselves. So intentionally broad in nature, the career span competencies apply to RMTs working in all practice settings, including clinics, hospitals, home-based practices, spas, educational institutions, research facilities, and administration. As a regulated healthcare professional, it is the responsibility of all RMTs to implement each career span competency in a manner that is consistent with their personal practice situation. That is the purpose of this, is that you have these 15 career span competencies, recognizing that everybody's in a different place in their career. It is deliberately broad in nature, which allows anyone to fill it out in terms of what they need to do to reflect and expand their knowledge base for practice. So, for example, one of the core competencies in these is to practice in a self-reflective manner, hence the reason why we've been talking about this today. By this we mean that all RMTs regularly take time to consciously think about their practice, analyze their decisions and their effectiveness, and draw on external information to achieve continuous learning and quality improvement. So ultimately, if you think about all the things I've talked about in this screencast, and everything that I talked about in semester 2 in Professionalism 2 about reflection and reflective practice and understanding yourself, understanding your patients, understanding your knowledge base, and so on and so forth. That's what this statement says. And if anything, do take this one statement away, is that we want you to consciously think about what you're doing when you're practicing. What is it you're doing? Ask yourself, why am I making these decisions? What has caused me to make this decision? And to recognize whether or not it's effective or not. And if it's not, am I recognizing that? If it is, why is it? Looking for more information outside yourself, whether that is an article of research, whether that is in a journal, whether that is discussions with your peers, whether they be massage therapists, chiros, family doctors, or whatever they may be. But ultimately, you are continuously learning, thereby creating a larger and larger database or knowledge base, and therefore you are increasing your quality as a massage therapist. And this is what we mean by quality improvement. You will be a much more qualified and highly sought after, high quality therapist. Thanks, and as I said, there'll be a number of things we'll talk about on Friday. In regards to this, I'll also go over the Strive with you in Friday's class. I will see you on Friday this week. Thanks for listening.